Hi, you guys. It's Dr. Baker Townsend, and I want to talk to you about hypertensive disorders in pregnancy. This is a major issue in the United States and worldwide. The reason why we have an higher occurrence in the United States or higher incidence is because we are delaying childbearing. And as you know, hypertension increases with age. So many women are waiting till after 30 to childbear. And many women are overweight, and being overweight increases your risk for hypertension. So you guys, there are a lot of risk factors that go into this, and we're just going to talk about hypertension. So the significance and incidence is it's a common medical complication. A lot of people have hypertension during pregnancy. We know that if you already have some degree of hypertension, it's only going to get worse. All hypertension is a vasoconstriction. Many people say it's mechanical. Um, so you guys, you already have a compressive force on the vessel, and then you don't have the ability to vasodilate to accommodate the extra fluid. So that's why pressures can go sky high. So they're a major cause of perinatal morbidity and mortality worldwide. It's usually due for babies. It's due to uteroplacental insufficiency, the high pressure to the placenta and across the gap. That high pressure damages the placenta. And with damage to the placenta, we know we get calcification, and then we can get a major vasoconstriction just from the placenta being damaged in itself. So we'll look at the pathology here in just a bit. So we know that babies can suffer. And then, of course, it can cause premature birth because it can cause damage to the placenta, which can send us into preterm labor, or it can cause an abruption. And the maternal deaths worldwide, 10 to 15% can be attributed to preeclampsia and eclampsia. So preeclampsia is more than just hypertension in pregnancy, and we'll talk about the ominous features that preeclampsia has. But once you're preeclamptic, then you can also have seizures. And so seizures with hypertension and ominous features is called eclampsia. So when you become eclamptic, it's a major risk. We already know that there's a lot of ICP, and you can actually herniate your brainstem. Preeclampsia accounts for more than 50,000 maternal deaths per year. Morbidity is due to renal failure, high pressure to your kidneys. Your kidneys are very vascular. We get kidney damage. Coagulopathy. We get a major coagulopathy that happens if preeclampsia is unrelieved. We have changes with fibrinogen and fibrinolysis, and then you guys, we have platelet problems. So all this, we have serious problems here. Cardiac and liver failure. Cardiac failure because we get so hypertensive and we retain so much fluid that our heart cannot handle the overload, and we can develop CHF from this. And then liver failure, because of the high pressure to your liver, it damages your liver and you have elevated liver enzymes, and you can actually have renal failure from this. Placental abruption, we know when the pressure is too high, it can cause the placenta to shear off the lining of the uterus. Seizures, that would be eclampsia. And then stroke, when the pressure is just so high in your head, you blow a vein and you have a stroke. Mortality, so pregnancy-related hypertension accounts for 10 to 15% of maternal deaths worldwide. Here's my little diagram that I made for you so that, oops, sorry about that. I don't know why that's up there. So that you can see when these things happen. So chronic hypertension is when it's before 20 weeks. So when you walk into the pregnancy with chronic hypertension, that is a huge risk factor because we already know we have some vasoconstriction. We know that's a huge risk factor for further gestational hypertensive problems. But after the 20th week of gestation, so let's say that your blood pressures were completely fine weeks 1 through 19. After week 20, if your blood pressure goes up over 140/90, because we all know that's what hypertension is, it's then called gestational hypertension. If you have gestational hypertension with some severe features that I'm going to talk about, that's called preeclampsia. Those severe features with a seizure is called eclampsia. So unfortunately, what we try to do is we want you to get as close to term as we can. We would love for the baby to become, um, we'd like to be the baby to be full term. But if this is a major maternal and fetal hazard, we may have to deliver you as early as 20 weeks. I've been in deliveries that were 22 weeks because of gestational hypertension and preeclampsia, and we knew that that the mom would probably expire if we did not do the delivery. Of course, the baby did pass, and the mom had a mild stroke. One of my cases, mom had a mild stroke. But you guys, this is very serious business, and so we're going to deliver you if you're really sick at any gestational age. I showed here that unresolved preeclampsia or eclampsia can result in HELLP syndrome, and that's a syndrome where you have coagulation problems we'll talk about. If that is not resolved, then we will go into DIC, disseminated intravascular coagulation. You guys, this is very hard to recover from. Many times people do not come back from DIC. As we know, they lose all their clotting factors. They bleed out of their nose and out of their IV site. So very important. So what is the cure for gestational hypertension? Delivery. So you guys, once you're delivered, the likelihood of resolution is very, very high. Now, some people will have some gestational hypertension after they deliver. After they deliver in the early postpartum period. But you guys, it's a very small percentage, but it very much can happen. And we know that it's some type of trigger that we don't know the patho yet. It has triggered during the delivery phase, and they still get super sick, and so we still run a risk of them dying as well. So I just wanted to show you about the weeks and when things happened. So gestational hypertension is hypertension without proteinuria or other systemic findings. Those are those ominous findings I keep talking about. Diagnostic for preeclampsia after the 20th week. And of course, the blood pressure needs to be 140/90 for it to be diagnostic. Preeclampsia is completely different than gestational hypertension, where preeclampsia is a pregnancy-specific condition. It only happens in humans, in which hypertension and proteinuria. So protein is a big molecule, so we know that we have a lot of pressure pushing over the protein molecule into our urine from our kidneys. So if you have 140/90 and proteinuria after 20 weeks gestation in a normally previously hypotensive woman, we then diagnose you with preeclampsia. Fortunately, this year they've changed the diagnosis where you can still have preeclampsia and not have proteinuria. You can have a blood pressure of 140/90, and if you have one of the following, then you're defined of having pregnancy-induced preeclampsia. So thrombocytopenia, low platelets. So if your platelets have dropped, if they're less than 150,000 is really kind of our baseline. But if they drop below 100, that's immediate thrombocytopenia. Impaired liver function. So if you have elevated ALT or AST and elevated blood pressures, that's diagnostic. New development of renal insufficiency, so creatinine and BUN. If you have a change in your kidney function and you have elevated blood pressure, we say, of course, pulmonary edema. If you have fluid in your lungs and you have elevated blood pressure, that is diagnostic. And new onset cerebral or visual disturbances. So you guys, so much pressure to your optic nerve. So when you swell in your legs, of course, the fluid third space is out into the tissue, so you get edematous. But when you swell in your brain, there is no third space. So unfortunately, that fluid goes outside, sits right on the outside of your brain, increases the pressure to your brain, which is called increased intracranial pressure. And that increased intracranial pressure can cause us visual disturbance and headaches. Headaches is new onset cerebral. Headache. It's a big deal. So you have to have either, again, 140/90 with proteinuria or 140/90 with low platelets and impaired ALT, AST, change in your creatinine or bun, pulmonary edema, or new onset headache or visual disturbances. Eclampsia is the same thing except for you have a seizure. The irritation is so bad to your CNS because you have so much ICP that now you have a seizure. So onset activity or coma in a woman with preeclampsia, no history of pre-existing pathology. So you guys, she did not have epilepsy before this pregnancy. 50% of eclamptic patients develop the condition while pregnant, of course, and women can develop eclampsia in the immediate postpartum period, just like they can preeclampsia. So what is chronic hypertension? We know that's before the 20th week, as we had said, and it is, chronic hypertension. Chronic hypertension with a superimposed preeclampsia, you guys, that's when you have chronic hypertension and then you get proteinuria or you get thrombocytopenia, any of those things, and that is very ominous, you guys. Chronic hypertension with superimposed preeclampsia, that is super ominous because we already know you have trouble and now you're getting into more trouble, and we can see it with your labs. So the etiology for preeclampsia, as I said before, it's only in humans. Risk factors are prima gravida's first time pregnancy in a woman less than 19 or over 40. So the young and the old, this affects. We don't know why. First pregnancy with a new partner, very interesting that they say your risk goes down with the same partner. But say, for instance, you had preeclampsia, or let's say you didn't have preeclampsia your first pregnancy, but you got a new partner, you run the same high risk that you did as a prima gravida. Very interesting. Something about sperm antibodies. If you had a history of preeclampsia, then you run the risk of having it again. Pregnancy onset snoring, because a lot of that is, well, we know that women in their head, all of that estrogen causes all that compression of of structures in the head. And so we know with snoring that there is some compressive factors there. So if there's new onset snoring, we're concerned about that. The cause of preeclampsia is unknown. There are very many theories. We know that it has something to do with vascular compromise and activation of vascular constriction, but we don't know exactly the mechanism that makes this happen. So pathology, it's a progressive disorder as the placenta is the root cause. Once the placenta is gone, that's how I keep saying delivery is the cure. Delivery is the cure. Once the placenta is gone, we remove the majority of the factors. We know that there's a small number of people who have it early postpartum. Begins to resolve when the placenta has been expelled. Spiral arteries in the uterus normally become larger and thicker to handle the increased blood volume. And so what happens, you guys, they dilate out, they're big, they're trying to perfuse that gap with as much oxygen as possible. And so we know that these spiral arteries can get compression. This can be a major problem for the baby because the baby, if these arteries are compressed, the baby does not get as much oxygen. This vascular remodeling does not occur or only partially develops in women with preeclampsia, and decreased placental perfusion and hypoxia result. So that's the problem, you guys. We get that vasoconstriction there. So here is what it looks like. Here's the pathology and how the placenta, what happens here is inadequate vascular remodeling in those spiral arteries, decreased placental perfusion, and hypoxia to the baby and to the uterus. This causes endothelial cell dysfunction throughout mom's whole body, which then in turn creates vasospasms, increased peripheral resistance, which you know is going to increase your blood pressure. So now we've got a narrowing of the vasculature. We have increased peripheral resistance, so we know that we're going to have higher pressures, and then increase endothelial cell permeability, which makes us be able to third space some of that fluid out and be able to retain it. That equals decreased tissue perfusion. And so not a good thing. We can have lots of problems as far as inadequate oxygenation. Um, Placenta becomes ischemic because we have damage to the placenta, we have hypoxia to the placenta, there's endothelial cell dysfunction, general vasospasms, poor tissue perfusions in all organ systems. We've talked about this. Increased BP, increased endothelial cell permeability, reduced kidney perfusion because we have vasoconstriction, plasma colloid osmotic pressure decreases, decreased liver perfusion, but we have high pressure to the liver, and that's going to cause damage to the liver, increasing the ALT and AST. Neurologic complications, of course, we're going to get some ICP. The ICP can be so bad that it can herniate the brainstem. We never want it to go there. We want to always ask, do you have a headache? Do you have a headache? Do you have any visual changes? If they have a headache, we start to be concerned. Also, we ask, do you have any right upper quadrant pain where the liver is? So that can tell us if we're having any complications. But neurologic complications, headache, we always say blurred vision, dizziness, and then epigastric pain, pain in your liver, so that we're trying to detect if they've had any problems. You can see that the vasospasms and decreased organ perfusion leads to all of this. For the placenta, uteroplacental spasms, intrauterine growth restriction, glomerular damage, kidneys, we get damage there, increased plasma, uric acid, and creatinine, oliguria, less than 30 mils an hour, cortical brain spasms, headache, hyperreflexia, and seizures. Retinal arteriolar spasm because of the pressure, that is blurred vision and scotomata. You guys, this is very ominous. Blurred vision and scotomata, very ominous. Liver ischemia, elevated liver enzymes, nausea and vomiting, epigastric pain, right upper quadrant pain. So now you guys, we have problems whereas we have damage to the walls of our vessels. So that high pressure damages our vascular and arterial walls. And you guys, when that blood hits the walls so very quick and fast, it damages the red blood cells. So then we have hemolysis of red blood cells. So now we've got issues with decreasing red blood cell counts, decreasing hemoglobin and hematocrit, and we already have all this stuff, so it's just an insult to injury. So you guys, we have increased platelet adhesion because where those walls are damaged, the platelets are going to adhere to the walls. That is going to consume our platelets in the vasculature. If it's really bad, we're going to throw out all of our clotting factors, our fibrinogen, and you guys, if the platelets aren't doing the job, we're going to throw out all of our clotting factors. So now that clotting factor, when you throw them all out in DIC, in the initial early states, you can throw a clot or you can form a clot. After all those clotting factors, fibrinogen, fibrin, all of those have gone out, then you guys, there's nothing left. And then you can die of DIC from just the ability not to clot. And then increased factor 8. Increased capillary permeability and leakage, proteinuria, again, that big protein molecule crosses over the kidney as in the urine, generalized edema, third space fluid. You guys, it's totally normal to have third space fluid in your legs, not normal in your hands or in your face. Pulmonary edema, we don't want third space in our lungs. Of course, she's going to complain of dyspnea. And then hemoconcentration. So she may have an increased hematocrit, even though we don't expect it, simply for the fact that she's lost all of the plasma out into the third space. So you guys, if this is not relieved, if we do not deliver, let's say we're trying to get the baby to 30 weeks, like we're trying to give her betamethasone or steroids to get her to a place where the baby's lungs can function. So sometimes we wait until the labs become ominous and then we deliver. So you guys, with preeclampsia, if that is unrelieved, you can transition into HELLP syndrome. Laboratory diagnosis for a variant of severe preeclampsia that involves hepatic dysfunction. So you guys, it is hemolysis of erythrocytes. So we know our red blood cell count decreases um, from damage of the red blood cell actually hitting the walls of the vasculature. Elevated liver enzymes from the hypoxia, ischemia, and high pressure, and then low platelets. Low platelets have to do with vascular remodeling, and so you guys, those and from your actual liver, from the damage to your liver. So you guys, hemolysis of electrolyte of a hemolysis of erythrocytes, elevated liver enzymes, and low platelets are all HELLP syndrome. And you guys, that occurs if you do not relieve preeclampsia or eclampsia. Again, result of arterial vasospasms, endothelial cell dysfunction, and fibrin deposits. Adherence to platelets in the blood vessels, as we've discussed. The clinical presentation is often non-specific with HELLP syndrome. You guys, sometimes they'll have an elevated blood pressure and they'll just say, ouch, it hurts a little bit right here, and they'll point to their liver. And everybody thinks, maybe that's musculoskeletal. Maybe the baby's kicking her. Well, it could be liver damage. So it's very non-specific. They could have malaise, or they could just think, oh, I'm just tired from pregnancy, but it could be from this. Influenza-like symptoms, fever, coughing, irritability, pain, right upper quadrant abdominal pain, and then symptoms are worse at night and improve during the daytime. Identifying and preventing preeclampsia, there's no lab tests. So all we can do is look at the labs and tell if she is becoming preeclamptic based on the proteinuria or the other ominous features, or we can see if she's getting HELLP syndrome. But there is no test for preeclampsia. Low-dose aspirin can help in high-risk women, especially women, Arabic women. We know they're at very high risk for preeclampsia. So we can do that, and of course, you know, the platelet effect of the platelet issue here is what really helps, is with the aspirin and the antiplatelet factors. Potential biomarkers being investigated, tyrosine kinase, and serum placental growth factor. What we do know is that when serum placental growth factor decreases and then there is some changes with the placenta, we know that those are triggers for preeclampsia. So you guys, they're trying to figure out exactly what it is so that we can do it. Abnormal uterine artery Doppler velocimetry in the first or second trimester of pregnancy is very ominous, because we know that there's already damage to those uterine arterioles, and so that can tell us what is in store for us in the following course of the pregnancy. I should have said velocimeter, sorry about that. Okay, so nursing care, assessment and nursing diagnosis, you need to accurately measure their blood pressure. You need to use the right size cuff. You need to have them laying on their left side. That's the first most important thing. Now, assessment of edema. Of course, we know that it's normal to have edema in your legs, but certainly not in your hands or your face. We used to include that in the diagnostic criteria, but we no longer do. Deep tendon reflexes, we know when the CNS is irritated, we know that that will increase how rapid your DTRs are. So you guys, +3 DTRs are brisk. Really hyperreflexive is +4 DTRs. So anytime we have an increase in deep tendon reflexes, we're start to be concerned. When your DTRs are so increased that you develop a secondary reflex called clonus. This is when we take your foot, we pull it back, and your foot will beat against our hand, beats of clonus. This is when we know you have severe preeclampsia that is warranting seizure interventions. So when you have clonus, you need to be prepared for a seizure. Now, 1 beat of clonus is bad. Certainly 4 beats of clonus is very, very ominous for a seizure. Proteinuria, we can remember if you have 140/90 with proteinuria, that is diagnostic criteria alone. So we can do a 24-hour urine collection. Of course, we have her void, then start her urine. We put the urine on ice, collect for 24 hours, send it off to the lab. Signs and symptoms that are related to severe preeclampsia. And actually, these are symptoms. These are not signs. Headaches, epigastric pain, right upper quadrant abdominal pain, and visual disturbances. Mild gestational hypertension and preeclampsia without severe features. We really, you guys, if they're doing fine and they don't show any really bad lab ominous features, we really just want to keep a very close eye on them, and we want to get the baby as close to term as we can. We just don't want any poor maternal or fetal outcomes. Home care, maternal and fetal assessment, activity restriction, and of course diet. We want to make sure we don't keep them sodium free. We have some sodium, but we're very careful. Goals when you're caring for gestational hypertension and preeclampsia is just to be safe. Intrapartum care, they need to be on bed rest with the side rails up. We darken the environment just to decrease the CNS irritation. We get her family out that's screaming or yelling or causing loud disturbances. All of that just causes more CNS irritation. So you guys, we definitely darken the environment, make it quiet. Now we can start the medication, magnesium sulfate. Magnesium sulfate, and this is a very serious medication. And this medication, you guys, is an awesome medication because what it does is it relaxes the central nervous system. And as a side effect, it lowers blood pressure because what it does is it relaxes the walls of the vasculature. So when the walls of the vasculature are relaxed, as a side effect, it lowers the blood pressure. And then of course we can give antihypertensive medications. Postpartum care, we want to monitor vital signs, check DTRs, level of consciousness. Of course, you always want to check level of consciousness when you are dealing with these patients because we know that the high pressures can cause a change of consciousness. 30% of all cases of eclampsia and HELLP occur postpartum. Again, a small amount. And really, that's really not small. That's a decent amount. But you guys, they had the features during labor. And they're unable to tolerate excessive blood loss because their vasculature is so compressed. All that extra fluid they have is now out into the third space. Future healthcare, 7-fold risk of developing it again in future pregnancies. Very scary. And then increased risk of adverse outcomes. So what is eclampsia? It's the same thing as preeclampsia, but with seizures. So immediate care. If they have an aura, if they have a persistent headache and blurred vision and elevated blood pressure, you better be ready. Also, if they have clonus, clonus is a sign to us that they may be ready to seize, so that you can be ready for that. Epigastric or right upper quadrant pain, altered mental status from the ICP, convulsions appearing without warning. Our job here is to ensure the patent airway and client safety. So, you know, when they're seizing, the baby's getting no oxygen. So we need to have the side rails up, have them padded, make sure anesthesia is aware, and maternal stabilization. You guys, when people are seizing, you guys, the baby gets no oxygen. So a lot of times we do a stat C-section. Chronic hypertension interventions, 45% of pregnant patients. You want to manage it before we start. And you guys, as from a clinician's point of view, we try to run their blood pressures as close to 139 over 89 as possible, just so that we don't drop their pressures so low that the baby does not get adequate food or oxygenation. So you guys, really important. And people always say, "Oh no, her blood pressure is like 135 over 85. Don't you want to give her more meds?" And we're like, "No, we don't. We don't want to drop that placental perfusion." Um, we want to get her started on meds prior to pregnancy. We know that ACE inhibitors and ARBs, anything that is renal in nature, is completely contraindicated in pregnancy. So if someone is of childbearing age, we really don't want them on an ACE. We want them on a beta blocker, so that it will not damage the kidneys of a developing fetus. Chronic hypertension is associated with increased risk of abruption, superimposed preeclampsia, increased perinatal mortality, intrauterine growth restriction, and preterm birth. Postpartum complications, pulmonary edema, renal failure, heart failure, encephalopathy, all of those are related to fluid. And so you guys, very important that you watch them. Thank you.